The following podcast is part of a certified educational activity titled A Modern Take on a Classic, Overcoming Today's Hepatitis Immunization Hurdles with Recent Guidelines and Practical Strategies. Access the entire activity and complete the post-test at peerview.com/SHN860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Robert Gish of the Hepatitis B Foundation. Welcome to this educational activity on overcoming today's hepatitis immunization hurdles with recent guidelines and practical strategies. Joining me in this discussion is Dr. Stacy Truskin from the Mazzoni Center.
Thank you. I'm glad to be here.
Our goals for today are highlighted here. First, we would like to expand your understanding of the impact of hepatitis A virus and hepatitis B virus infection, including transmission rates, clinical features, and risk factors for severe disease and poor outcomes. We want to provide you with the ACIP updated guidelines for hepatitis A and hepatitis B vaccination. We wish to improve your ability to use professional patient dialogue regarding HAV and hepatitis B vaccine recommendations to address disparities and barriers in diverse adult populations. We wish to equip you with multidisciplinary, interprofessional strategies for optimal prevention of HIV and HBV infection in accordance with updated guidelines. I'll begin now with an overview of the epidemiology and burden of hepatitis A and B. Let's talk about hepatitis A first. The burden of hepatitis A in the United States comes from different pillars, different portions. We have health outcomes, we have economic costs, we have management strategies. There's quite a bit of detail on here, giving you a variety of different studies that have reported on health outcomes, a number of studies on economic burdens, as well as outcome and outbreak management considerations. Quite a bit of detail here, but I think this would be great for your ongoing review. As you recall, we've had some severe outbreaks of hepatitis A. I live in California. I live and work in San Diego. This was a major foci where a hepatitis A outbreak took place that I think really spread throughout the United States. And this was predominantly in those individuals with housing instability and lower socioeconomic status. And importantly, a variety of them already had underlying liver disease from other causes. Let's talk about epidemiologic patterns of hepatitis A. One, we have this lower socioeconomic status, but this is acquisition typically by age 5. And this is typically in high seroprevalence areas or regions, and typically has an asymptomatic or mild clinical course. In the Pacific Islands, there's waves of epidemics that take place in varying severity by generation. And what we mean by generation, we mean by age. The older the age of the individual infected with hepatitis A, typically the more severe the disease. And once you get into the 60 to 70 age range, you can even have fulminant hepatitis A. In developed regions, US, etc., higher socioeconomic status, you can still have these waves of outbreaks that can occur in adults. Lack of exposure during childhood, lack of vaccination during childhood, and it's typically from foodborne outbreaks, but very importantly, it can also occur in homeless environments, unstable housing environments. And I mentioned the San Diego outbreak in 2016 through 2018, which took place mostly in the downtown San Diego area, in places where homeless were living on the streets. They didn't have clean sanitation, access to bathrooms, and hand washing. The number of reported cases of hepatitis A infection and estimated infections in the United States takes us on this graph up through 2021. I've lived in California for 30 years, and about every 7 years, there's been waves of hepatitis A infection they're typically also foodborne, we believe brought in by the immigrant worker population. And then that next wave hits the unexposed, unimmunized individuals and then recycles about every 7 years. So we may be heading towards another cycle, 2025 to 2026 in our region. Here is source of hepatitis A infection, and I think it's important to be thinking about household transmission and maybe sexual transmission. Daycare could be child to adult, adult to children, then back and forth. Unknown, this is typically, in my opinion, foodborne. If you're in a higher socioeconomic status, more stable housing, and an unstable housing is going to be person-to-person transmission. And then international travel is also an issue. People need to be tested and vaccinated before they travel internationally. At-risk populations, here we've outlined a little bit more detail for you. And of course, when you have an outbreak in a family, you would need to be thinking about intramuscular immune globulin, but more importantly, vaccination in those individuals or testing before vaccination. There's a pretty big emphasis here on sexual transmission. People with clotting disorders, I think it's because they have a number of underlying different forms of chronic disease and comorbidities and maybe at higher risk for more severe disease. Clotting products per se don't typically transmit hepatitis A. And back to chronic liver disease. We've known for over 2 decades that individuals with chronic liver disease, if they get hepatitis A, will have a more severe course. Clinical presentations is this full spectrum from asymptomatic to symptomatic to fulminant liver failure. And there is this cholestatic relapsing disease. It's not chronic hepatitis A, but it's a relapse that can evolve and have cholestasis present for up to 6 to 7 months. And I have seen that in my practice. I only see it about once a year. And I don't have a predilection. What individuals are more likely to get this relapsing or prolonged cholestasis? Who should get vaccinated? A lot of detail on this slide. We've already talked about who those high-risk individuals are. And this kind of takes you backwards saying, should I be vaccinating an individual? Do they fit any of these specific parameters? So surveillance is important. We do have hepatitis A as a reportable disease. We talked about this recent decline in hepatitis A cases. I think it has to do with waves of awareness, waves of testing, waves of infection, and waves of vaccination that bring about a time period of immunity in previously susceptible individuals. We have these high rates in these different age groups up to 50 years of age. And of course, there's some regional differences, Eastern and Southern, although California is not Eastern or Southern. We had definitely an outbreak starting in 2016 here. 14 states have declared an end to outbreaks among individuals who use drugs or experience homelessness. Back to testing and vaccination, we can break that cycle. National Progress Report here up through the 2025 goals, reduce estimated new hepatitis A virus infections by over 40%. And I think we're on a trajectory for this, which we're not seeing in our hepatitis C or our hepatitis B worlds. Let's now talk about hepatitis B. Of course, B is for bad. The epidemiology and burden of hepatitis B in the US has been well defined. You really should be using the term up to 2.4 million people, surface antigen positive. That comes from a paper that Robert Wong and I published just about two and a half years ago. Acute hepatitis B infections have followed the hepatitis C problem because of the opioid epidemic and lack of adequate harm reduction, education, of course, testing and vaccination. And we're really, really trying to move that dial. Hepatitis B rates are higher in men than women for some reason. Men more likely to have chronic disease than women. We're not fully aware of what the genetic or environmental patterns are there. But Right now, of course, hepatitis B, 70% in the US is an immigrant population, typically first generation immigrants. And they're typically from the Asia, Pacific Islanders, or Africa region. MENA also, Central Asia would be listed here as well. And of course, once we have hepatitis B testing, we need to stage individuals, start doing surveillance for liver cancer at the appropriate times. But remember, hepatitis B vaccine is the ultimate anti cancer vaccination. Weighted average of chronic hepatitis B of all foreign born people, 3%. 60% of US residents with chronic hepatitis B immigrated from the Asia region, and then 19 and 15% Americas and Africa. 25% of individuals are diagnosed, and that's why we have this new standard to test all adults for the triple panel, not any single one of the tests or dual testing, but it's triple panel testing that's very important. Transmission, this is blood transmission, but mother to baby, could be intrauterine or during delivery, and there's no difference between C-section and vaginal delivery. But we really have to think about vaccination as prevention of transmission. And of course, we could even talk about treating hepatitis B as a reason or a justification to help decrease transmission. Needle use, tattooing, of course, needle sharing, other percutaneous tools such as acupuncture that aren't cleaned appropriately. And this is an STD. So we really think about hepatitis B vaccination as a way to change that transmission route. So again, it's now test everybody with triple panel negative, vaccinate everyone. We've really made this very, very simple. By vaccination, we can stop disease initiation. Vaccine is not going to change progression, but by preventing disease, we change these outcomes of cirrhosis, decompensated disease, death, liver cancer, and liver transplantation. We know that we can decrease liver cancer by 99%. Taiwan has led the world in vaccine and liver cancer prevention, and they've found a profound change in the first 20 years by decreasing liver cancer in children by these logarithmic levels. This is reported cases of acute hepatitis B. We're back up to 2021. We saw this spike, but the spike really preceded COVID, but I think paralleled what was going on in the opioid epidemic. Now, this recent decline may have to do with more testing and more vaccination. So I think we are seeing some encouraging signs here. A little bit more details on surveillance are on this slide. Just want to highlight some general numbers. Acute hepatitis B, 0.7 per 100,000 persons. High among people up to 50 years of age, 40 to 50. But in my practice, which covers a very large geographic area in California and overlaps with Nevada, I'm seeing maybe one acute hepatitis B case per year. I think a lot of this has to do with the fact it's asymptomatic. People may carry surface antigen long term or become just core antibody positive. And risk data is missing. People in these surveys don't want to report their risks specifically. And this may be due to privacy issues. I think that's one of the concerns. And people just don't want things in their medical records due to discrimination and due to stigma. Newly reported hepatitis B among API persons, 14 times the rate among non-Hispanic whites. And this is because hepatitis B is transmitted horizontally. It's transmitted in households by methods we're not quite sure, but that's why you test everybody in a household as top priority. We're testing everybody anyway, but test those household individuals and get those individuals vaccinated if they're triple panel negative. Our progress report is present here up through that 2025 goals, but we've got data out to 2021 with some projections. We've got some encouraging information. We wanted to reduce new infections by greater than 20%, and there's a suggestion that we have this trajectory moving forward. A little bit more on this in a subset, which is this is among PWID, people who inject drugs, people who use drugs by 25%. And I think we're on or nearly on that trajectory as well. Reduce hepatitis B related deaths by 20%. I don't think we're on that trajectory. And I believe that this is an issue of undertreatment. Our guidelines are phenomenally complicated, 36 pages, 400 references, 19 different boxes. This is too difficult. We're really moving, such as the Chinese guidelines, to treat everybody. There was a very interesting, I call it a correspondence in Lancet that just came out this week from the World Hepatitis Alliance about this test all, treat all approach. Let's make it simple. A little bit more on the progress report about effects or trajectory in the API person community. It looks like we're on a reasonably good trajectory to make changes in this population. I'm just trying to check if I've missed any points. Stacy, I'm going to bring you back in and ask you is there one or two or three areas we should highlight a little bit more? And what do you think might be missing from these introductory discussions?
No, I thought that was great, Bob. I think the most recent statement you just made about the need for harm reduction is really critical. For maybe folks in our audience that are less familiar with some of the modalities for harm reduction, things like as simple as drug treatment programs, safer sex, tools that making condoms readily available, allowing individuals to attend syringe service programs so that they can have clean syringes, and other works to keep themselves safe if they're not ready to stop using drugs. But those types of things really are critical when we think about elimination, when we think about really reducing risk for things like hepatitis B. And then certainly for hepatitis A, harm reduction includes taking folks who are experiencing homelessness and making sure that they have access to hygiene, that waste disposal is available for them, and hand washing stations are available. So all of that, I think, is really evidence-based public health intervention that, as you mentioned, has a political overlay, but is really an opportunity to help us get our numbers of new cases down even further.
I was driving, I went by this very interesting and I thought well designed tent city in San Diego. And I saw all the hand washing stations lined up. I saw the sanitary, communities, the toilets all set up, looked very clean. It was being supervised. So, we can help the homeless community and help our entire community by being really proactive. And we have a team in San Diego, which is led by Christian Ramers and the family health centers. And they have these mobile clinics and they're everywhere, testing, helping, harm reduction, vaccination. It's really an amazing service for our community. I work in City Heights. It's a huge immigrant population with very little homelessness or housing instability in that zip code. That has a lot to do with the churches and a lot of the other social community supports that are there that also partner with what we do in a federal clinic, the FQHC, which is where you work as well. So it's these cross-community partnerships that are going to make a difference. They are making a difference. We're starting to see some very nice trends.
Okay, I'd like to move us on to talking about vaccination recommendations for both hepatitis A and B. And the good news here is that there are options. There are options for both viruses. For hepatitis A in particular, there are two options for hepatitis A, an activated vaccine that are in two doses. One that is approved for age groups, or both actually, that are approved for age groups 1 to 18. And there's a combined hepatitis A and B vaccine that's administered in a 3-dose schedule as well. For individuals that are greater than or equal to 18 years of age, there's a vaccine schedule for primary vaccination and also for accelerated vaccination, which has a 4th vaccine booster at 12 months. And so These vaccines are highly efficacious. I'll show you some data shortly. I also just want to mention that there is immune globulin available for both pre-exposure and post-exposure prophylaxis against hepatitis A infection as well. For pre-exposure prophylaxis, if somebody is going to be planning to travel to an area with higher intermediate hepatitis A endemicity, it's a good idea to get pre-exposure prophylaxis. If you're going to be away for 1 month duration, there's a dose available. 2 months duration, you give twice that amount. And then also for post-exposure prophylaxis as well, within 2 weeks of exposure, there's also vaccine dose. So there are lots of opportunities here to prevent sort of the negative outcomes of hepatitis A vaccine. And as I mentioned, highly efficacious, very immunogenic. More than 95% of adults will develop protective antibody within 4 weeks of just a single dose. We try to get ourselves to 100% by doing that second dose as well. And then more than 97% of children and adolescents will in fact be seropositive within the first month of the first dose. So this is a really great vaccine that we have available to us. And we've had tremendous success with the vaccine as well in terms of incident cases. In 1995, hepatitis A vaccine was first licensed in the United States. You can see here from this graph that cases almost immediately started to decrease. However, as Dr. Gish mentioned, in between 2016 2018, we started to see recent outbreaks that have threatened that progress. The ACIP hepatitis A vaccine recommendations were again updated in 2020. Vaccine right now is recommended for all children aged 12 to 23 months, and also for unvaccinated children and adolescents aged 2 to 18 years. We also are going to recommend vaccination for individuals who are at increased risk for hepatitis A infection, including people that are traveling to endemic areas, so international travelers, men who have sex with men, people who inject drugs or use non-injection drugs, anyone with an occupational risk for exposure as well, and then individuals who would anticipate close personal contact with an international adoptee, and people who are, of course, experiencing homelessness. We also want to make sure we're vaccinating individuals who are at increased risk for severe disease. So that means anybody with chronic liver disease. We know that hepatitis A infection on top of cirrhosis can lead to a fulminant hepatitis and death. And so we want to prevent that from occurring. Anyone with HIV should also be vaccinated for hepatitis A as well. And then any pregnant women or pregnant people who are at risk for hepatitis A infection, or who would have a severe outcome from hepatitis A infection. And then also, if somebody wants hepatitis A vaccine, we should certainly give it to them as well. In terms of hepatitis B, we also have a lot of options. So there is a 3-dose recombinant vaccine. Trade name is and engerix as well as recombivax. This vaccine can be given to all ages and is safe during pregnancy. This is a 3-dose vaccine that's given at 0, 1, and 6 months. There is a 2-dose recombinant vaccine as well, marketed as heplisav. It's marketed for individuals 18 and older, and in non-pregnant individuals, 2 doses given 1 month apart, which can be very convenient when you are concerned you may not have access to that individual to give that third dose. There's also that Twinrix vaccine, which I mentioned before. It's the combination of both Hep A and Hep B vaccine, all ages, 3 doses given at 0, 1, and 6 months. And then lastly, there's a pediatric vaccine that protects against either 5 or 6 diseases, 3 doses given following the birth dose of hepatitis B vaccine. We also have one more addition, PreHevbrio, which was added February 2022. It can be used as a hepatitis B vaccine in individuals 18 or older. And this is given 0, 1, and 6 months up to age 44. It's FDA approved. It is, again, a highly effective vaccine, greater than 90% protection among healthy adults who complete the 3-dose Hep B series. And it's estimated that greater than 90% of persons had evidence of protection even 30 years after receiving the primary series. So it is an enduring immunity, which is really important to consider when vaccinating individuals. So we have made great progress in the fight against hepatitis B. As you can see from this graph, there have been numerous public health interventions to drop the number of cases that we see in this country over the last really 40 years. We're going to talk a little bit about how the recommendations for vaccination have changed over that time, but you can see that we now have plateaued in the number of cases that are reported, but we still have a significant amount of work to do to get us down to 0. 2023 was an exciting year in the space of hepatitis B. There were some significant changes to screening and testing recommendations that have been largely applauded by the public health community. Screening is now recommended for all adults 18 or older at least once in a lifetime. It's also recommended for anybody who requests it. And as Dr. Gish mentioned, we now are using a 3-test panel. We should be screening with surface antigen, surface antibody, and also core antibody. So that sort of triplet of tests should be ordered collectively together. So if you're working with EMRs, electronic medical records, you want to get that order set combined so that your providers can order it with one click of a button, remembering that this is now standard of care for any individual aged 18 or older. We also recommend screening for all pregnant people during each pregnancy, preferably in the first trimester, regardless of vaccination status or history of testing. And it's also recommended for anyone with a history of risk, any age at all, and periodic testing for susceptible folks with ongoing risk as well. So, who should receive hepatitis B vaccine according to the ACIP? That should be every infant, any person less than 19 years of age, anyone between the ages of 19 and 59, and then adults greater than 60 or equal to 60 with risk factors, right? And so I think that covers a large base of our human population. So it's really something that we should be thinking about for everyone. So here's this evolution of how hepatitis B immunization strategies have changed over the years as data and public health and the epidemiology of the virus has changed. In 1982, the recommendation was to vaccinate groups that were at increased risk for hepatitis B. Then we moved to vaccinating all infants in 1991. So anyone born in the United States should be vaccinated for hepatitis B. We moved in 1999 to anybody age 0 to 18 years of age should also be vaccinated. In 2005, this concept of the birth dose, so a vaccination given right at the time of birth to get folks started on their vaccination journey, was recommended. And then anyone less than or equal to 59 years of age with diabetes was added in 2011. So again, things have evolved over the years. In terms of risk-based hepatitis B immunization, we only saw partial success in the impact on the epidemiology here. We initially saw decreases in new hepatitis B infections, then plateaued about 10 years ago. Rates now are highest among adults, and unfortunately, rates of hepatitis B infection have increased among adults 40 years of age or older. And you can see that in the graph here. There's sort of an olive green line where you can see the trend has been upward, which is opposite of what we want to be seeing when we have so many good vaccination options available to us. there are profound limitations of a risk-based approach when it comes to vaccination. The acknowledgement of risk, whether it's an individual just not being aware of what their risk may be, or the stigma associated with risk, those all impact our ability to accurately have patients report and for us to assess risk. So 2/3 of reported cases of hepatitis B were either missing risk data or had reported no identified risk. And you can see here on this pie chart that risk for hepatitis B infection was identified only among 33.1%. The vast majority of individuals just didn't have any risk data reported. So when we're vaccinating based on risk, we're missing things. And so this universal approach to testing, universal or more expanded approach to vaccination is really what's needed for us to move closer towards elimination. So what does Hep B elimination look like? It means we should be testing all adults and we should be vaccinating all newborns. That really is the crux of what will get us to hepatitis B elimination. It's critical to remember that hepatitis B is vaccine preventative, but it's not curable. Suppressive treatment also lowers risk of liver cancer as well as cirrhosis. So with that, Dr. Gish, I want to just invite you to chime in and add any additional thoughts about hepatitis A or B vaccine recommendations that we have at our disposal now.
Stacy, I wanted to ask you about this final policy of the hepatitis B triple panel, including core antibody. I got pushback. I've been advocating for that for over a decade, as you know. I've written review papers on it, all the value of the core antibody. There was a lot of fake news out there about core antibody for a while, that it had a high false positive rate. But were you convinced, especially with the Malika Toy paper, that core antibody is part of the three legs of this chair of testing?
Yeah, I think it's a great addition. It provides you with some additional information about what exposure might have looked like in the past and allows you to counsel patients and make decisions appropriately. So I think it's a great step forward. And certainly in our health center, I work in a federally qualified health center. It it it's something that we've packaged into an order set to make it very simple for our providers to just order it all at the same time. Hep B screening should be part of any new patient assessment, along with HIV, along with hepatitis C testing. It's just part of routine opt-out screening that we provide. Similarly with like cholesterol testing and a lipid panel, it's just part of routine care. And I think if we can find workflows that really allow us to order those three tests as a set, it takes some of the thought out of it, and it makes it more likely that all of them will get done at the same time, and you get the full picture of what somebody's status is.
Speaking of order sets, that's a great segue. I am seeing patients every week who are coming to see me with fatty liver or other chronic liver disease, occasionally acute, but mostly chronic. And I'm seeing hepatitis A IgM and hepatitis B core IgM. It drives me crazy because these two tests aren't quite worthless, but they're only worthwhile in a very special setting. How do we get the labs to make those two tests, second level testing, where people have to think about it to order it? And instead, they get the total hepatitis A antibody and hepatitis B core total automatically. How do we get the labs or the providers to change?
Yeah, I think it's tough to get a large reference lab to remove a test or to add extra layers to the ordering process. So I really do think it's at health systems level or within individual practices to really take a close look and figure out, okay, what are the tests that are meaningful to us as a practice, and how can we support our providers when you're seeing patients very quickly, you need to move through fast, you want to have those order sets at your disposal so that you can say hepatitis B screening and it automatically pulls the correct test that you're really looking for in. And similarly, it's the same way that we've changed in many of our practices, ordering hepatitis C antibody test alone, which is not particularly useful if it comes back reactive. You really need that second reflexive PCR test. And so making sure that we've taken out those unwanted, less desirable tests and substitute them in with the preferred tests, and making those the ones that individuals automatically reach for. I mean, we're such a computer technology driven world now that we have to make that work for us, not against us. And I think there are ways to do that with our workflows and leveraging our EMRs to help us.
I've been very thankful for this simplicity pathway because Twinrix, when I get the right hepatitis A test and it's negative and their B panel's negative, we're saving 2 injections. It's just fantastic to give Twinrix. And of course, they're getting the Twinrix 3 times. So they're probably hepatitis A immunity is super immunity, but it really does decrease workload. And every time you decrease a step, I think you have better compliance. And that's why with the heplisav-B, which is a 2-dose for hepatitis B, I'm super happy. And I'm happy with PreHevbrio because even if somebody only gets 2 doses, this is off label, of course, but they just get 2 doses, they still have a very high antibody titer because the way the PreHevbrio is set up with these multiple antigens. So we've got lots of tools in our vaccine world. And I just want to make that comment on what my practice looks like every day. I talk about vaccine with every single patient I see, which during a given week might be 100 patients.
Yeah, it's critical. I think, to your point, having the tools in the toolbox, having the right tests, giving the vaccination, we have what we need to move us closer to elimination. We have now recommendations around testing that should help support that. It's really about the implementation at the ground level. So now that we've talked a little bit about vaccination recommendations as well as testing, now let's talk a little bit about how we're assessing and addressing health disparities in vaccination for both hepatitis A and B. So there is a viral hepatitis national strategic plan, a roadmap to elimination for the U.S. That's supposed to take place between 2021 and 2025. And it really highlights the need to address the social determinants of health and the priority populations that are disproportionately impacted by both of these viruses. And so many populations that are disproportionately impacted by viral hepatitis face disparities in health status related to social determinants such as low paying or inconsistent employment, unstable housing, people who are experiencing homelessness, race, ethnicity, geographic location, and then certainly other characteristics or experiences that are linked to things like discrimination, stigma, and exclusion, or just lack of access to care. Negative interactions too with healthcare providers or other social service systems can also decrease the likelihood that individuals will seek care, making viral hepatitis risk assessment, testing, linkage to care, even prevention, as well as treatment, more difficult and certainly less accessible. And this all poses additional and very unique challenges to the development of broad-based, widely applicable solutions. We really need to think about how we target our public health interventions to meet the needs of every population. And that requires some specific honing and attention. So who is receiving hepatitis A vaccine? So among adults that are 19 or older, hepatitis A vaccine coverage was higher in 2021 than it was in 2018 overall. And that's impressive, I think, because of the pandemic, right? We know that lots of individuals were not necessarily accessing care. And so that's encouraging. Coverage was higher among travelers, 33.8%, than non-travelers, just 19.3%. And among all adults 19 or older, coverage, though, among white adults was higher than Black, but lower than in Asian adults. And so that is concerning, too, that there is a health disparity there. Among adults aged 19 to 49 years, white adults had higher coverage, again, than Black patients and Hispanic adults. And so clearly there are access to vaccine issues that we need to be addressing and building better models of care to do better. The likelihood of receiving hepatitis A vaccination was looked at by this one study that was retrospective from both rural and urban populations, and found overall only 15% of people had received hepatitis A vaccine despite an appropriate indication. So profound under-vaccination. And among those hepatitis A vaccine receivers, white individuals and non-Hispanic and native English speakers had the highest percentage, suggesting that there was in fact some disparity among who received vaccine. When we think about hepatitis B, the reported cases of acute hepatitis B infection do show some health disparities. Now, keep in mind, too, that hepatitis B acute infection is not always symptomatic. So a lot of these cases represent like tip of the iceberg. These are just the individuals that came to the attention of a medical provider who are counted in these numbers. And so when we think about access to care and data that looks at health disparities, there may be even additional health disparity work that needs to be done to accurately assess who's being impacted here. But even with those underlying access to care issues, among race and ethnicity data, you can see here that Black non-Hispanic individuals have had higher rates of cases reported of acute hepatitis B infection compared to their white counterparts. And so although numbers have decreased over the last 2 decades, we still see that disparities exist. We see this data here too with chronic hepatitis B, not just hepatitis A. And if you look here first at age group, per 100,000 population, the overall rate is 5.9 per 100,000. When you look at the age breakdown here, this is going to be more common among individuals 40 to 49 years of age, followed by 30 to 39 years of age. And then when you look at the race and ethnicity breakdown, you can see that individuals who are Asian Pacific Islander have higher rates per 100,000, a whopping 27 per 100,000, followed by Black non-Hispanic individuals as well. And so higher than the overall rates, and certainly higher than individuals who are white non-Hispanic. And so again, work to do here, demonstrated by this health disparity data, to really make sure that we're vaccinating individuals and engaging these individuals in appropriate treatment to try to reduce health disparities and certainly the negative and long-term sequelae of infection. And then rates of death with hepatitis B listed as a cause of death among U.S. residents. Now, again, caveats here while we're looking at data, cause of death on death certificates, not always the most reliable data, but when it is there, it certainly is indicative of the presence of that infection. And so when you look here too at cause of death data as broken down by race and ethnicity, you can see again that Asian Pacific Islanders disproportionately impacted, as similarly to Black non-Hispanic patients as well. When we think about vaccine coverage by race, ethnicity for hepatitis B vaccine, you can see that Mexican Americans and African Americans have lower vaccination rates than their white counterparts. So when we think about that data of acute infection as well as chronic infection, it makes sense that we're seeing those negative outcomes because also the vaccination data demonstrates that there are health disparities present. When we think outside of race and thinking about other health disparities that exist, let's take a moment to look at men who have sex with men. Here, among MSM traveling internationally, self-reported hepatitis B vaccination prevalence was in fact 77% overall. It was highest for men aged 18 to 40, and it was less prevalent among men older than 50 years of age and those with HIV infection. Only 1/3 of HIV positive men reported not being vaccinated. Hepatitis B infection prevalence was 25% overall and was associated with Black men, older age, and HIV co-infection. Lastly, if we take a look at health disparities through the lens of people who inject drugs, who also have evidence of hepatitis C exposure, they're antibody positive, you can see that there are some additional disparities that can exist. Here, when we look at hepatitis A vaccination, greater than 1 dose, you can see that we have somewhere between 30 and 40% that in this study population that were vaccinated. And so certainly in the presence of hepatitis C, potentially co-infection, here we just know antibody status, and individuals who may be at risk for experiencing homelessness and acquisition, we would want that number to be 100%. We would want everyone to be vaccinated according with ACIP guidelines. And certainly for hepatitis A vaccine, 2 doses, again, we'd want that number to be significantly higher. When we think about hepatitis B vaccine completing a 3-dose series, you can see that for individuals 20 to 29 years of age who maybe benefited from that birth dose, the rate is 81%, which is great, not perfect, but getting us closer to where we want to be. But when we start to look at individuals who are older and maybe missed the recommendation for birth dose and earlier childhood vaccination, you can see that there's still not appropriate coverage, that with individuals aged 40 to 49 years, only having 25% of those individuals completing a 3-dose vaccination series. So a lot of work to be done there, certainly to be in compliance with the ACIP recommendations for vaccination. So what are some of those barriers to vaccination at risk populations? So certainly access to healthcare, sometimes educational attainment too, can be identified as key barriers to vaccination, certainly among Latinx and Asian migrants and immigrants. There are fewer foreign-born women were insured than U.S.-born women. So access, particularly in states that have not expanded Medicaid coverage, can be a profound issue as well. And then limited English fluency and not knowing where to go for vaccination is also a challenge. And so making sure that everybody has access to free vaccine is a critical piece of this too, to reduce health disparities. It really is also a health equity issue, and disparities could be further reduced with a universal adult Hep B recommendation. There are still some rules that we have to be following that make it a little bit more complicated, but rates of hepatitis B infection for children and adolescents of all races and ethnicities converged to a lower rate when a universal vaccination strategy was implemented for children less than 18 years of age, and current rates among Black American adults are now up to 3 times those of Asian Pacific Islanders and Hispanic groups. And all of this together really drives home the point that racial and ethnic disparities really do remain in hepatitis B virus infection. And so we still have quite a bit of work to do there. But again, we have the tools to make that happen. So Dr. Gish, I know you have a lot of thoughts about this and certainly salient to the work that you do. So can you share with me some strategies that you think we should be implementing to improve vaccination rates in those at-risk populations.
Well, you've covered EMR, you've covered education, you've covered simplified policies. Now we just have to make a conscious effort to double check that chart. To me, the biggest problem is I have these super busy clinics and I can't find their hepatitis A and B test results. They've often come to see me through a gastroenterologist, and I'm assuming they were tested. I have been wrong so many times, Stacey. I now hand search each chart and then I put it in my problem list, which is inside, for instance, Epic, and I track it and make sure I've got ABCs on every single person. It's going to take effort, but we've got a motivation because we can change the future of liver health through doing these very simple strategies. The other thing, I think you're going to talk about vaccine hesitancy, or I will cover that in a moment. But it's interesting. I don't see much. The only hesitancy that I still see is making sure people are up on their COVID vaccines. But when I talk about hepatitis A or B vaccine, people go, sure, which is nice. So we're getting there. I may not be representative. We can chat a bit more. Anything else that we need to emphasize in our last few minutes here?
I think that there are a couple other strategies that I want to highlight. One of them is a public health intervention that I see with vaccination registries. So our electronic medical record now interfaces with our departments of health's vaccine registry. And so I can often see even individuals that have transferred care to me recently, when did they get their last set of vaccines? And do I see hepatitis B on there? Do I see hepatitis A on there, even at their first visit, which is wonderful. What's hard for me, though, is that if someone has moved from out of state, I have no idea, and I have to wait to get the medical records or to get their test results back. And so that's an unfortunate piece. So it would be amazing if we could somehow as we expand how our electronic medical records talk to each other, have access to countrywide registry for vaccination so that we could have a better understanding of where individuals are in their vaccine journey. And I think the last piece is really similar to what we were talking about before, which around harm reduction, which is really bringing care to individuals, integrating and embedding the care that individuals need, rather than having them navigate to see a specialist or even into a primary care office, but thinking about going to shelters that take care of people who are experiencing homelessness, or to the syringe service program, or street side even, and making sure that we're providing appropriate testing and appropriate vaccination for individuals so that we can make sure that they're getting what they need. Some of those barriers around insurance, around feeling safe or even heard in a medical provider setting, I think a lot of that can be overcome if we go to patients and if we go to populations and communities that are at greatest risk. I think that's how we start to reduce health disparities in these areas.
So in the last few moments, we'll be talking about this interprofessional approach to vaccination. I'm going to move pretty quickly here because I think we've covered most of those. So I'll use this opportunity to talk about best practices. We did talk about vaccine hesitancy, and there's a number of steps that we can use to address this. And a lot of times it just takes me to tell my patients, look, I've been vaccinated. I've had 8 COVID vaccines. I've been screened for B. Unfortunately for B, I've been exposed. I'm core antibody positive, probably from when I was a medical student. And of course, I'm hepatitis A immune, probably because I was traveling all over the world all the time. I was exposed at some time. But it's nice to know about this hesitancy and be able to work through that with your patients. Here's even more strategies. I call these the do's and the don'ts. But I really take a very non-confrontational approach with my patients, just like I use in my fatty liver patients or my substance or alcohol use disorder patients. I use a little portion of motivational interviewing. What's your motivation for good health? What might be a motivation why you are hesitant, and then try to get to the root of that in a positive partnership fashion. So motivational interviewing, I think, is one of the most powerful tools that's entered the medical community over the last few years. It's changed my life and my practice. It's just amazing. Improving vaccine rates, I really think, unfortunately, in our world, or fortunately, our primary care providers are carrying the great weight that's here. We, as subspecialists or specialists, I think, need to see the more difficult patients. We've empowered our primary care providers to treat HIV and now hepatitis C. Hepatitis B, as you know, 70% is in the primary care community or general gastroenterologists. And I think this vaccine process, especially what you talked about, registry, EMRs, one thing, maybe an app would help people. They have a vaccine app and somehow all their data gets in there electronically or by hand. But we need to collaborate with our general provider partners, including our APPs that are there. The generalists and specialists are in this integrated team in many settings. With my FQHC, my rural health clinic, I have great partnerships with primary care. I'm constantly training them. 70% of the liver care in my FQHC is in the hands of a specialized primary care provider that I've trained. He's my partner in all this. And fortunately, our EHRs there, at least in the federal clinic, have all the vaccine records if we can access those. Epic's a little bit more spotty because Epic requires some hand entry and hand tracking from either the provider or our medical assistants. Nurse practitioners and PAs are extremely important part of this. And one thing we really want to emphasize is pharmacists. Whenever I talk to a patient about getting vaccinated, I used to send it always to the primary care provider, but really now I put pharmacies first, primary care provider second, and then I'm the backup to make sure these things get done. I think COVID really brought the vaccine awareness and implementation to our pharmacies, which I think is a fantastic step. Nurse practitioners' knowledge and adherence to ACIP has been researched here, and there's a movement of improvement as we go into education. There's a lot of details on these slides. These will be available for download later. Take a look at this. If you're in the APP community, take a look at this important research that has taken place. Back to pharmacists. I went through pharmacy school before I went to medical school. I felt at that time pharmacists were overtrained. We had so much knowledge that was underutilized, especially in the community setting. Hospital setting, I think even 20 years ago, pharmacists were well utilized. But now we have pharmacists at the front line, like an icebreaker of getting vaccines of all types. If I get vaccinated for something, I go to one of the pharmacies in San Diego. That's where I get all my vaccines done, not at my primary care provider. So pharmacists are a key part of this team. Did I miss anything in this wrap up, Stacy? Things you would like to emphasize? I have one more question for you after you put your points on the table.
No, I think you got it all. I really do.
Can I ask you a question about birth dose vaccine? I read with great fascination the paper in New England Journal of Medicine from Jourdain, who I know personally, and they did a protocol where they were giving the B vaccine within 2 hours of birth, and there was a hint that that would obviate needing a nuke for the mother if she's infected with B, and also eliminate the need for HB because that vaccine so early in that birth process stimulated the immune system quickly. But I've talked to Calvin Pan, who's one of my gurus of the Hep B vaccine world, and he doesn't see that the data is that clear. What do you think about the 2-hour birth dose?
I mean, I think the 2-hour birth dose in general is starting somebody off on their vaccination journey like with some zest, right? Like you're getting started early, you're making sure it happens. I think I agree with your guru in the sense that it's probably too soon to make any determinations about what is or is not then needed based on that. I think that we need a lot more experience with what the impact of a 2-hour birth dose is going to be on a population level. But I think, getting the first vaccine into somebody soon after they join us in this world is a great start, and that we can see what the impact is going to be in the years to come, and then go from there.
All right, my final comment is every provider needs to know their A, B, C, D, E's. We've been talking here about hepatitis A and B, of course, and know how a vaccine is integrated into the total patient care, not just the liver patient care, not just about liver health, but total patient health. And in summary, there have been ongoing outbreaks of hepatitis A in the US, especially since 2016, but it really predates that about every 7 years over the last 2 to 3 decades. Rates of acute hepatitis B have risen in states affected by the opioid crises. We talked about the total number of surface antigen positive patients. About 6% of the population is core antibody positive, and 40 to 60% of the immigrant population is core antibody positive. They don't need vaccine. I want to make sure that's very clear in this summary. The CDC has its viral hepatitis strategic plan, and we're looking good for hepatitis A new infections and reduction. It looks good, not great, but good for hepatitis B reduction as well. This universal hepatitis B vaccination recommendation after the triple panel, I think will help reduce disparities in vaccination rates as that gets implemented across all of our patient populations. And the key is we're part of a team, we're part of a partnership with our colleagues and with our patients. Thank you much for joining us, and I hope you found this program to be useful as you continue to care for your patients at risk of hepatitis. And thank you, Dr. Truskin, for being here and contributing your insights to the discussion.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/SHN860.